Hi, my name is Paul Howland. I'm one of the anesthesia residents here at UCLA Medical Center. And this is going to be a brief talk on how to assess a patient under general anesthesia in a systematic fashion. And it's entitled, So How's the Patient Doing? Because oftentimes you'll take over a case, or your attending will walk in while you're taking care of a patient, and they'll ask you this question: so how's the patient doing? And I hope that by going through a system, you will feel much more comfortable in answering this question. A brief outline of what this lecture is going to cover includes where this idea came from, what the approach is going to be, taking a systematic format, including the listed systems. In addition, pointing out how important it can be to think like a pilot. What this won't cover, however, is the intimate details of anesthetic depth, including MAC and its definition, as well as how it was developed, neuromuscular monitoring, hemodynamic assessments, vent management. All of those things can be taken care of in an isolated lecture that can go on and on and on in detail. However, I will touch on a few details of each one of those things as it relates to the system, and pointing out useful tips that hopefully you'll take with you to the bedside. So I just want to take a moment to thank Dr. Jason Lee and Rob Kamdar. They introduced me to this concept of systematically assessing the anesthetized patient under general anesthesia independently. In addition, I want to thank Dr. David Hindelman for providing a pilot's perspective, and you'll understand what I mean a little later. Before we get into the details of the system, I want to take a step back and address a few broad points. The first of which is the recognition that anesthesia can be very overwhelming at first. When you walk into an operating room and the patient's under general anesthesia, there's a lot of moving parts, a lot of complex machinery, a lot of things that are changing both acutely and subtly that can be very overwhelming to try to take in all at once. And so if you feel this way, know that you're not alone, and we've all gone through it. The second thing I want to emphasize is the need to maintain a clean workspace. You'll notice in this picture a little towel has been laid out with some medications resting on it. There's no trash around. And this seems somewhat like a moot point. However, in the setting of a crisis like acute hypoxemia or hypotension, where you have to act fast and maintain calmness and control, a clean workspace can make the difference between a stressful situation or one that is smooth and easily handled. Again, when you walk into a room and you're giving somebody a lunch break, or you're taking over a case and there's trash everywhere, the drugs are not organized efficiently, it can be, it can make tough situations unnecessarily harder. This next point I want to emphasize is that the system we're going to discuss is just one way of doing things. It's important that you just find a system that works for you and repeat it constantly. Muscle memory is very important, and once you have your system down, deviations from normal will be easier to recognize even in the setting of crisis. I also want to point out that you always need to know where your backup emergency equipment is. It should never be assumed that your anesthesia machine is always going to work 100%, and you should always be ready to move on to emergency equipment in the setting of failure. And this would include things like an ambu bag, knowing how to turn on the auxiliary oxygen canisters in the back of the machine or wherever they may or may not be located. Lastly, I want to emphasize the need to know where your Pyxis machine is, which should be next to the anesthesia machine if you happen to work in a hospital where there is a Pyxis machine in each OR. Have it logged in so you can quickly access drugs in an emergency, and also open up the computer record so right when the patient hits the door, you can start generating data and accurately obtain information necessary for the anesthetic record. Okay, the first system that I assess when I am looking at an anesthetized patient is the neurologic system, and I take a head-down approach. The first two questions that I ask myself are, is this patient anesthetized, and is this patient paralyzed? And deciding if a patient is anesthetized is somewhat easier with inhaled agents, simply because we have the MAC value that can help us estimate how anesthetized the patient is. When you're using something like Tiva, there really is no MAC equivalent other than serum levels, which are integrated into some pharmacokinetic pumps in Europe, but those have not been adopted in the United States yet. A couple words about MAC, though, is you can find MAC on the anesthesia machine on this particular Draeger model here, and sometimes it's reflected on the vital sign monitor as well. But I want to point out that not all MAC values are created equal. I know that MAC by definition or 1.0 MAC is the amount of inhaled anesthetic that is required to prevent movement in 50% of the population in response to a surgical incision, usually midline laparotomy. However, there are different reasons to utilize inhaled agents other than just preventing movement, because if the patient's already paralyzed, you're really utilizing MAC for the more important aspect of amnesia. In other words, you're utilizing MAC awareness. So you can run a MAC level around 0.7, 0.8, and the patient is likely not to be, or I should say, the chance of awareness is greatly minimized. So just be aware of what it is that you're using MAC for. In addition to using MAC, you can decide if the patient is anesthetized by peripheral indicators such as vital sign changes, if they're profoundly tachycardic or hypertensive, and of course, if they're moving and the surgeon's like, hey, he's kind of wiggling, or he's bucking the vent, or the peripheral indicators of anesthesia. Secondly, when I ask myself, is this patient paralyzed? Of course, we utilize the train of 4, in particular using accelerometry at UCLA. And I took a little clip of the monitor that you can see here. These little 4 bars reflect the different twitches from the train of 4. And this number here reflects the train of 4 ratio as it compares the 4th twitch to the 1st twitch. So, of course, this is great. Usually you have to level or calibrate the monitor before you paralyze somebody. And on occasion, these things can be a bit finicky. So don't forget that in the anesthesia machine, you also have the old school twitch monitors that you can apply to a patient. In addition, I always consider positioning, because when you think about the nervous system in terms of central versus peripheral, patients are unable to tell us if they're uncomfortable. So you want to make sure that you examine your patient as you're assessing the neurologic system for the potential for peripheral neuropathies developing, such as if the arm is abducted more than 90 degrees, you could run the risk of developing a brachial plexopathy from too much stretch in the armpit. So don't forget about the peripheral nervous system with respect to positioning when you're thinking about the nervous system. So moving down from the head, I like to assess the cardiac system next. And the question that I ask myself is the current blood pressure appropriate for this patient in this surgery? And the reason I phrase that question in that regard is, of course, you want to know that the patient's blood pressure is enough for organ perfusion. However, there are types of surgeries where particular blood pressures are targeted, whether it's, maintaining a low blood pressure, like during liver resection where you do low CVP anesthesia, or if it's during, say, a cerebral aneurysm clipping, et cetera, et cetera. So just being mindful of those goals. So this monitor has lots of great information. Starting with the ECG, we utilize leads 2 and either V4 and V5. This lead 2 to detect arrhythmia, since it gives a great picture of P waves, and then V4, V5 as it helps us to detect ischemia, particularly anterior wall ischemia. So you can quickly ascertain, a regular rate and rhythm by looking at, the rhythm itself, making sure it's free of ischemic changes, at least in this particular lead, along with the heart rate here. Next, you can look at your blood pressure. And this monitor here has both an invasive arterial line as well as a non-invasive blood pressure cuff. Also, if you happen to have an invasive line, some monitors will actually automatically pump out a pulse pressure variation number that will help you guide fluid resuscitation. I also want to point out, don't forget about end-tidal CO2 when you're thinking about the cardiac system, since it's sort of a poor man's cardiac output, and that if blood flow to the lungs diminishes because of diminished cardiac output, then your end-tidal CO2 will decrease if you haven't made any vent settings. So when you're thinking about this, you also need to remember the old equation from physiology of cardiac output equaling heart rate times stroke volume, and then the three components of stroke volume being preload, afterload, and contractility when you're assessing the cardiac system, especially when you encounter issues like hypotension as you're generating a differential. I always find it useful to fall back on that equation. And of course, you always want to think about the patient's baseline, because 120 over 49 or 114 over 68, it sounds like a reasonable blood pressure. However, if somebody's coming in and their baseline blood pressure is 200 over 100 because they do a bunch of meth, or they're poorly controlled hypertensives, and maybe they have dialysis and they skip it all the time, the cerebral autoregulatory curve could be shifted to the right in those patients, and they might need a higher blood pressure. So don't be falsely reassured by blood pressures or vital signs that fall into, quote, normal limits. Keeping this simple, there's other things that you can use to assess the cardiac system, of course, TEEs, SWANs, and CVPs if you happen to have a central line. In addition to answering this question, I like to remind myself to check those drips, meaning if the patient, whatever is infusing into the patient, you should be mindful of, whether it's a vasoactive drug, an antibiotic, immunosuppressant if you're doing a transplant. It's very important to figure out what's going into the patient, and also that it's going in at an appropriate rate to help you avoid something that I call the CA1 bolus. And I say this as a joke, because when you first start, you will induce the patient, put the fluids wide open so the drugs flow in, intubate, and you're so overwhelmed by what's happening that by the time you look up at that bag that you hung in the beginning, it's completely empty and you've inadvertently given a bolus. And of course, for a large majority of patients, this is semi-harmless. However, in patients with heart failure or CKD, it has the potential to be deleterious. Lastly, it's important to know your lines. In other words, you need to always know where your IVs are and that they're functional. If you are starting to give drugs and you're not getting the response that you want, and when previously you were, it's always a good thing to keep in mind that perhaps the IV is no longer functional. So assessing the respiratory system is next in my particular system. And of course, the two goals of the respiratory system are to oxygenate and ventilate the patient. So I always phrase my assessments in questions. So the first of which would be, are we adequately oxygenating this patient? Of course, this is semi-easy to ascertain with pulse oximetry, found on the monitor here. Of course, this gives you another wealth of information in addition to the percentage of hemoglobin that's saturated, as well as the pulse rate. But this also gives you an indication of perfusion as well, because if this line starts to get finicky or decrease, or it has a difficult time picking up the reading, it could give you an indication that your perfusion to the distal extremities, if you're measuring this on a finger, might be decreasing. In addition, it's kind of hard to see in this picture, but there's a little caret right here. This is important to keep in mind. This gives you an indication of the quality of the signal. So if you look over and this number gives you something that raises your own blood pressure like 70, you want to make sure, number one, that the pulse waveform is appropriate, but also that this caret is completely filled, as it again gives you an indicator of just how strong and quality the signal is. And of course, outside of SaO2, you can always run a gas to determine the patient's PaO2 and to help calculate an AA gradient if you're worried about the patient developing hypoxemia. My second question I like to ask is, are we adequately ventilating the patient with minimal to no leak at reasonable lung pressures? And this particular question can be answered by looking at the ventilator on this Draeger model here, starting with end-tidal CO2. Of course, the faster that you breathe or the deeper that you breathe, the more CO2 that you blow off. So it's pretty easy to look at this number, but also to appreciate this waveform. This is a pretty normal looking waveform. However, I would refer you to some of the more well-established anesthesia textbooks to review some of the different types of pathology that can be picked up on this CO2 waveform. One other thing to point out is that, this number is smaller than P little a CO2, this being P big A CO2 because of dead space. So when you're targeting your end-tidal CO2 to whatever level for whatever reason, just be mindful of that. Moving down, I look at the tidal volume and I compare it to the set tidal volume, and it helps me determine if I'm delivering the set tidal volume without a significant leak. And in this machine, there's this little thing called delta V. So when the patient when the ventilator delivers a breath, the machine will then measure the breath that it gets back during exhalation and will compare the two. So if you happen to be delivering a breath of 500 and the patient gives you back 250, then you have to ask yourself, well, where did the other 250 cc's go? It's unlikely that the machine is so compliant or the tubing is so compliant that you simply lost it to machine absorbance. It more or less would signify a leak somewhere. So this little delta V is super helpful in this particular machine. And of course, while you're looking at the tidal volumes, you can look at peak and plateau pressures. It was previously told to me that the machine itself doesn't actually have plateau pressures because technically there's no inspiratory pause. However, in the machine settings, in this little extra settings button, you can actually find an option where you can add an inspiratory pause of a certain percentage to help you tease out a plateau pressure. And one other thing I want to mention is, do you know where your ambu bag is? I find this to be an overlooked, extremely important aspect of assessing the patient, or at least being mindful of what you're going to do in an emergency. You always need to know where your backup emergency equipment is, as emphasized in the beginning. So when you're thinking about the respiratory system, just always be mindful of where's my ambu bag in the event that this anesthesia machine fails, because it can be life-saving. Just a couple other thoughts on some of the other organ systems that I think are often underappreciated given our preoccupation with the neurologic, cardiovascular, and respiratory systems. With GI and endocrine, you can always think ahead of time if this patient's going to need an NG or an OG tube post-operatively, whether or not they're being extubated. Especially actually if they're being extubated. When I was in medical school, our surgery clerkship director had us put these an NG tube in one another, and I can tell you with certainty that that was one of the worst experiences of my life, and it made me very much mindful of the experience that patients go through with placement of NG tubes while they're awake. So in other words, it sucks. So it's way better if you can have this in place when the patient wakes up. Also, with TPN, when patients are brought down, from the ICU or the floor and they're on TPN, we generally leave this running, and we check blood glucoses, usually Q hourly, but not just on TPN. This is just to remind you that if you have a patient that has tenuous, blood sugars for a variety of reasons. Maybe they're in septic shock or DKA, or they happen to be on an insulin drip for whatever reason, to think about the need to check blood glucoses. And then, of course, with renal and GU, you can consider urine output when you're assessing a patient. And you should never assume that a Foley is present. And I mention that because you want to be mindful that the anesthetized patient, at least with an intact urinary sphincter, is unlikely going to be able to urinate until they wake up, because if you pound them with fluid, their bladder is going to get distended. It could be one of the differentials for unknown tachycardia or hypertension. And the other thing to keep in mind about urine output is the impact of ADH. So, the body undergoing a big stressful surgery, causes the release of antidiuretic hormone, which can again decrease the amount of urine output. So, Uh, be mindful of that before you decide to pound a patient with fluids just to help their urine output pick up. Okay, so you've gone through your system, you've checked all the boxes, you feel pretty confident that the patient is doing well. Um, One last thing to do is to examine the room and think like a pilot. And Dr. David Hindelman is a fantastic anesthesiologist that we work with here at UCLA. And he actually is a pilot, and he teaches people how to fly private planes. So he reminded me that once you're kind of settled in and you think everything is done, to just start from your left, look at the extreme end of the room, and slowly but surely scan the room in a panoramic fashion, going from one side of the room to the next, all the way to the right side of the room. And in the process, you can pick up on things that you may or may not have thought about just by looking at them. Could be, the level of the SIVO or whatever inhaled agent's getting a little low. It could be, that you forgot to get the ABG machine in a big case where there's lots of blood loss to be expected, or that you forgot to plug in the bear hugger, or the CO2 is exhausted, or perhaps you forgot to turn on the hotline. There's so many little things that could be picked up on just by scanning the room in a careful fashion. So I would encourage you to adopt this, and I have found this very helpful in helping me, catch things that would have otherwise gone under the radar, especially if it's a red line case where there's a lot of things moving around, a lot of moving parts, the stress of the room is high. Always, again, fall back to a system. All right, let's put all this together and see just how fast and efficient we can assess this anesthetized patient and apply this system. So you walk into a room, you get a feel for how things are going from a global perspective. You see a nice clean environment, drugs are laid out appropriately, and then you move on to the system, starting with the nervous system, and you're asking yourself, is this patient anesthetized and paralyzed? They seem to be under general anesthesia. Looking at the MAC value, they definitely have enough gas on board to provide amnesia. They're also paralyzed, looking at the train of forward ratio and the twitches. In addition, I'm glancing at the patient's position and making sure that they're not running the risk of developing a peripheral neuropathy. Moving to the cardiovascular system, I see a regular rate and rhythm with an appropriate heart rate that's maintaining a blood pressure adequate for this patient, having known their baseline. Utilizing the invasive monitor, I see pulse pressure variation to suggest that they're adequately resuscitated. End-tidal CO2 is adequate. Looking at the drips, I see that I just have some plasma light running in the background, and it's not wide open because I actually remembered to clamp off the flow rate so it doesn't give the classic CA1 bolus. And I'm cognizant of where that 16 gauge PIV that I placed when the patient got there is running well. From a respiratory standpoint, we're adequately oxygenating this patient as reflected by the SaO2, 98%. It's got a good signal according to this carrot, the waveform as well. And I see that the heart rate is in agreement with the ECG, which makes me feel reassured that this is an accurate number. In addition, I see that I'm ventilating the patient at an appropriate end-tidal CO2 with a good waveform. I'm delivering the appropriate tidal volumes, and the patient's giving me back those as well. This delta V is not terribly impressive, and those volumes are being delivered at a reasonable pressures. This patient is undergoing routine lap appy, doesn't need an NG or OG tube, is not on TPN, don't need to check blood sugar, does not have a Foley, so I'm going to be mindful of not pounding them with fluid. Lastly, starting from the left hand of the room, I'm scanning, I'm thinking like a pilot, and I notice that I forgot to plug in my bear hugger, so thank God for Dr. Hindelman. In addition, I see that my ambu bag is hanging off of the Pyxis machine, so I feel reassured. In the setting of machine failure, I'm going to be able to ventilate and oxygenate my patient. So within a matter of minutes, I feel pretty confident when my attending walks in and says, "So how's the patient doing?" I say, the patient's doing pretty good, actually. Okay, in conclusion, keep a clean, organized environment. Again, develop a system that you can rely on during stressful times. Take a step back once you've gone through your system and think like a pilot and scan the room. And lastly, a shameless plug for UCLA. I think it's a fantastic residency program, and I highly recommend anybody interested in anesthesia apply. And if you're already done with your training, it's a great place to work. Lastly, this is my dog Stella. From a nervous system standpoint, she does not appear to be anesthetized. She seems to be breathing at a regular rate. Perfusion wise, I'm assuming that she's adequately perfused based on the color of her tongue and how hyper she is running around the room. So now I have to go walk her. I hope you've enjoyed this video, and take care.